So good evening, everyone. Thank you for being with us today. I'm happy to co-chair this third wave of complex series or complex series with Medtronic, with my co-chair, Dr. Omar Göktekin, who's joining from Istanbul. We also have a wonderful panel today with CTO experts from the region. Dr. Sharif Al-Biltagi is with us. Dr. Muhammad Atif has just joined in. Dr. Khaled Mandoor. We're still expecting Dr. Khaled Shukri and Dr. Nabil Farag. We will start to make sure we don't drag beyond our time limits. And these are my disclosures to get them out of the way. And I will start by a video from Andreas Grunzig, which I hope you hear the sound.
Depart on more total closures and try to learn how to deal with total closures, how to approach total closures, and to learn how to technically recolorize total closures. As you know, in peripheral dilatation, we do this all alone. Charles Stoddard did it in 1965 or 4, that he crossed the total closed iliac artery with a guide wire and pushed his coaxial catheter through, as he did it also in the SFA. Therefore, to cross total closures is not a new experience for me. I've known this since 15 years now myself. But the femoral artery is a different story than the coronary artery due to its anatomy. It's a nice straight line down the road, and you push the guide wire. If you're lucky, you find a distal lumen. If you're not lucky, you just finish the procedure. That's not that easy in a coronary because the heart, as you know, is beating, and you have curves.
Well, I find this amazing on many levels. This was in the mid-80s. So he had the foresight to sort of recognize that this is going to be yet another frontier to beat down the line, back in 85, my God. He also acknowledged the fact that this is different than the peripheral arena, where things are relatively easier. But the interesting thing is that he also had the foresight that the techniques and maneuvers that are being used in the peripheral intervention arena are also applicable in the coronary with some variation in the coronary arena. So that was back in 85. We jumped forwards around 35 years, and this was a white paper in circulation almost late last year. And we can see this is Omar is a co-author. This is 101 operators from 50 countries. 3 of them are from Egypt, Khaled, Tamam, Hussein Hishmat, and myself. But again, very good representation. And the concept here with Manos was to try to establish that CTO PCI is becoming more or less a standardized procedure. And there are key components to what constitutes best practice in the arena. And this is what I aim to take you through for the coming 20 to 25 minutes or so. One, the indication or the solid indication for CTO PCI is improvement of symptoms and improvement of quality of life. And if you look at the different randomized trials we have, and I won't get into details, but there are good trials that showed significant improvement in terms of quality of life. And all the trials that looked at harder endpoints, be it major adverse cardiovascular events or mortality, were either negative trials, similar like the EXPLORE trial, or negative trials with serious flaws in terms of how were they designed and how they were executed. So if you look at one of the biggest trials, Decision CTO, there are substantial limitations that make the conclusion very shaky, to say the least. So it was prematurely terminated after recruiting only 65%, and 77% of the optimal medical treatment arm end up receiving PCI to a non-CTO vessel. And there was no blanking period, so people frequently had PCI to a non-CTO vessel, followed by CTO to PCI to a CTO vessel within less than 2 weeks. So it was entirely impossible to discriminate whether the improvement in terms of hard endpoint was driven by revascularizing the CTO vessel or a non-CTO. We also had a 20% crossover rate from the optimal medical therapy arm to the CTO PCI arm. But without getting into the specifics of every trial, if you look at a meta-analysis with more than 20,000 patients, we see that there is a trend towards improved survival in patients who underwent successful CTO PCI versus those who underwent unsuccessful CTO PCI. So again, a very soft endpoint, but what we do have data for is CTO PCI is associated with substantial improvement in terms of quality of life for symptomatic patients. And this is the sort of solid indication we have today. And indeed, the 2018 European guidelines for myocardial revascularization do stress that angina that is resistant to medical therapy and slightly extrapolate data from non-CTO PCI to patients with large area of documented ischemia in the territory of the CTO vessel. So I will show you sort of the extreme in terms of patient presentation that does benefit from CTO PCI. This is a 55-year-old gentleman, sort of the conventional risk factors plus moderate chronic kidney disease, underwent CABG with 3 grafts 6 years earlier, now angina on mild exertion, mildly impaired ejection fraction, but not in clinical heart failure, and a multi-slice CT showed that all grafts were occluded, including the lemur. CMR, luckily viable myocardium in all territories. So again, a very young individual who's already undergone CABG, quite unlucky to have all 3 grafts occluded, impaired ejection fraction. And if you look at his angiogram done 15 months prior to presentation to our institution, you can see that he has a very large left circumflex, albeit with a very tight, almost subtotal lesion in the AV trunk. You can see that the LED fills retrogradely via epicardial collaterals from the circumflex. The RCA is totally occluded as well. And we already know from the CT that there is no grafts available. I think I can show you the lemur as well. And the lemur is going nowhere. So this was the angiogram when he presented to our hospital, and you can see the subtotal circumflex lesion, epicardial collateral to the LED, epicardial collaterals to the PLA of the right coronary artery. I think you can appreciate the anatomy here. So looking at the lesions, we had a very long LED. These are the CTOs, obviously, a very long LED lesion with an ambiguous proximal cap, mild disease in the distal vessel, tortuous epicardials, and the lesion length of approximately 60 millimeters. On the right coronary artery side, the proximal cap is slightly ambiguous, although we did have the impression that we can see it in some projections. The distal cap is at a bifurcation, tortuous epicardial collateral from the circumflex, and the lesion length is again almost 60 millimeters. So the plan here was a stage procedure, fix the LCX first. This is a non-CTO vessel, should be a quick fix, followed by the RCA and the LED, sorry, in the same session, give room for septal collaterals to grow from the LED side into the right coronary artery because the epicardial going from the circumflex to the right coronary artery was quite poor, and re-evaluate whether we have indeed septal collaterals that have grown and fix the RCA 8 weeks down the line. Given that it's an ambiguous proximal cap and a very long lesion length, both were planned to be primary retrogrades via the epicardial collaterals. So I won't get into the technical part, that's not the aim of the talk, but quickly we fixed the circumflex, got a cyan black wire through that epicardial collateral, went retrograde into the LED, dissected with a knuckle. You can see that on the left-hand side, the wire initially went retrogradely into the lemur. We fixed that by going subintimal distal to the anastomosis of the lemur, dissected, did a reverse cut in the proximal part of the LAD, and ended up putting 3 stents with an open LAD. Now, this was a 90-minute procedure, 3.2 grays, 220 contrast. Remember, this is a patient with moderate kidney disease. The good news, after 6 weeks, we do have indeed a septal perforator that has grown. So we now have a second access into the PDA rather than the very tortuous epicardial collateral. So that was good news. I think you can appreciate it here on the epicranial view. And that was an easy surfing through that septal into the PDA. And again, we can go quickly. A reverse cut, a bit challenging because it was difficult to get past the site of anastomosis of the RCA graft, which frequently is a site that would give us some trouble. So the only way we could dissect past this anastomosis site was with a Carlino with some hydraulic dissection. Then we eventually ended doing reverse cut in the distal part of the right rather than the proximal part of the right, secured the PLA with a dual lumen microcatheter, and finished with a patent right coronary artery with both branches open. Now again, a slightly longer procedure, about 4.1 grays to 130 cc's. So I think this is the type of patient who is gone from no grafts, very young individual, no option for surgery, but with CTO PCI techniques, you're able to restore complete revascularization and restore a good quality of life in a very young and deserving candidate. So the second principle with CTO PCI is dual coronary angiography and in-depth and structured review of the angiogram. Now, ideally, this is done with the whole team. We do spend 20 to 25 minutes reviewing the angiogram. This is not meant to be an ad hoc procedure. And I assure you, every time you spend some time looking at the angiogram, you notice some more details that can come in extremely handy during the procedure. As a matter of fact, dual angiography is not exactly new. This was first reported by David Holmes back in '99 as means of visualizing vessels in complex anatomy, and essentially complex anatomy was meant with a CTO when a CTO is present. So there are certain rules to a dual angio. You really want to have your full coronary circulation in the screen, so no magnification. You don't want to pan because the more you pan, you will lose some details, and you do want to see all the details and good resolution. We do a donor vessel first injection until the distal cap is opacified. Then we inject antegradely. And the concept or the objective is visualizing both the distal cap and the proximal cap simultaneously while understanding the collateral circulation in detail. We keep our foot on the pedal for some time to make sure that we understand that if there is any late filling from another source of collateral is important. I think Omar has an excellent slide, which I don't have something as good with right coronary arteries in particular. If they're the donor vessel, make sure that your catheter is not too much wedged in and you're missing a conus or a collateral filling from a conus branch coming from the right coronary artery. So this is also important. And obviously, you want to fix yourself in the angulation where you can visualize the CTO vessel, but also visualize the collaterals in detail. And you really want to end up with 4 features with clear answers to. What is and where is the proximal cap? Can you see it? Is it readily identifiable, or is it an ambiguous cap? What is the lesion length, and whether the body of the CTO has a lot of calcification or tortuosity, or you simply can't identify what the body or the course of the CTO vessel is, so what we call an ambiguous course. The second thing, or the third thing you want to identify is the quality of the distal vessel, and the fourth question we need an answer is what are the sources of collaterals? And the reasons are, this is how those 4 questions would translate into what technique should you choose. So if you have a clear proximal cap with good distal targets, an antegrade approach seems reasonable. If the lesion length is very long, your chances of staying true to true becomes very low. So a dissection re-entry, mostly nowadays using a crossbus Stingray or a bridge point system because it's more reproducible, becomes the strategy of choice. If it's a short segment or the course of the vessel is very clear in our minds, then wire escalation can work. On the other hand, if the proximal cap is ambiguous and or the distal target is poor, then retrograde becomes the more likely primary strategy. And again, if the lesion length, if it's a very long vessel or a poorly understood vessel course, you would go for dissection re-entry, which is essentially the first cut from the retrograde route, or wire escalation if the course of the vessel is clear or the lesion length is short. So this is how we would look at the vessel. Again, this is a CTO of the right coronary artery, donor vessel first, CTO vessel next. We understand the anatomy exactly, and we have a clear idea of the collaterals we want to choose. And it is actually advisable to write this down early on in your experience. So this is how we evaluate the angiogram: proximal cap, lesion length, distal vessels, good quality, interventional collaterals, yes or no, and whether the septal or epicardials or a combination of both. And then you put a plan that takes into account the anatomy you've just encountered. And again, for the sake of time, this was a straightforward reverse cut. So we've just discussed that evaluation of the lesion is not really an ad hoc procedure. You want to spend time doing that, preferably with the whole team. You want to determine the strategy, what is your primary approach, secondary, tertiary, and even your fourth or plan D. We want to determine complexity, what are the chances of success versus what are the chances of inducing complications, and is this really the sort of the risk-benefit ratio of the procedure in this particular patient, which is in all honesty a dynamic process. So we do that at the beginning of the procedure, but in a patient with a smallish right coronary artery where you fail to establish via an antegrade route and your only option is a very tortuous epicardial collateral that is likely to cause trouble, you really want to revise the risk-benefit ratio during the procedure itself. You obviously want to determine your access options, whether they're by radial, fem and radial, bilateral femoral, or occasionally 3 accesses, which is occasionally the case in patients post-bypass. Sometimes you really need a 4th access if this is a patient who's going to be on mechanical support. So determining your access options and planning in advance will save you a lot of time during the procedure. The third principle is the use of microcatheters. This is quite an essential part of CTO PCI, and the combination of dual angiography and the use of a microcatheter is actually 2 of the very simple maneuvers that can dramatically improve your success rates early on. And there are actually 2 things that when you revise an angiogram where someone is tackling a CTO without the use of either, you can sort of readily identify that this is not exactly someone who's spent enough time doing CTO training or CTO PCI. So the reason we use microcatheters is it allows you to establish a base of operations in front of either the proximal cap if you're working antegradially or the distal cap if you're coming to the retrograde route. So you have a firm base of operations. You can escalate and de-escalate with wires and use different maneuvers, but you've secured your position. It gives you better control of the guide wire tip because the body of the wire is not squeezed within the CTO body. It enhances your support and wire pushability. If you look on the right-hand side, the closer the microcatheter is to the tip of the wire, you get exponential increase in the penetration and support you get from the tip of the wire. You're able to exchange wire at different stages without losing progress. You can't really do retrogrades without a microcatheter because you need to protect your collaterals. You can use them for tip injection, for better delineation of proximal cap anatomy, and occasionally within the body of the CTO itself to delineate vessel course. And we used to say in the older days that a microcatheter or an over-the-wire balloon would do. Nowadays, we recommend against over-the-wire balloons because they're bulkier, they can kink easier, and you get the marker in the mid shaft, so you don't understand where the distal part, where the wire is exiting exactly. The 4th thing, which is at the heart of the hybrid algorithm, if you want to do CTO PCI and achieve an 85 or 90% success rate, you really want to have all the options under your belt. So you want to master antegrade wiring, ADR, and the retrograde approach because they're all complementary, and you really will require those as you face different anatomies and different degrees of complexity. And we now understand that as the JCTO score or the complexity of the CTO increases, your chances of antegrade wire escalation decrease substantially, and you will find yourself utilizing more and more of dissection and re-entry techniques, be it antegrade dissection re-entry or reverse cut. And this is indeed reflected in data from Progress CTO. This is just analysis from just over 6,000 patients. And you can see that as you progress with lesion complexity, antegrade wire escalation really doesn't serve you right. And you will progressively rely more and more on ADR in light blue here, or the retrograde approach in almost half the patients with JCTO score 4 and 5. Another key component of the hybrid algorithm is versatility and practicality. So we don't get stuck in a failure mode, and it's essential and important that we shift strategies in the middle of the procedure in sort of a dynamic and reactive fashion without getting stuck in one technique and spending half an hour repeating the same thing over and over again with more contrast and more radiation. So being able to change efficiently to alternative crossing techniques increases the likelihood of success, shortens the procedure time, obviously, and lowers the risk from radiation and contrast. And this is again from analysis from the CTO, from Progress CTO. And you can see that the primary strategy, be it antegrade, ADR, or retrograde, worked in around 50% of patients. But the second strategy was required in almost 1/3, and the third and occasionally fourth strategy was required to achieve an overall success rate of 87%. So it's important to keep this in mind. You want to keep your options open, and the only way you can do that is A, by being trained in all the above, but B, being able to move throughout those strategies whenever you think that you have exhausted your chances with your primary approach. Now, something we've been stressing on, and the CTO community is particularly one extremely supportive group of experts. So you will see Omar, I just see Tariq joining in, Dr. Sharif, Dr. Khalid, but both on the regional level and on international level, it's a very rich community in terms of exchange of expertise and people stepping in to help each other, be it to work together on different cases, help each other, help younger colleagues with proctorship. And I think this is one of the most important things, that you really don't want to do this on your own without the proper training, both in terms of sort of a graded exposure to increasing levels of complexity with help from an experienced operator, but also establishing a center that has the proper volume and the proper equipment, both for efficiency and for successful procedures, but also the necessary equipment that can save you or salvage the patient during complications. And I assure you, you will face complications with those procedures. So this brings us to a notion that we've always been stressing: doing CTO cases does not equate to having a CTO program. And what you really want is not doing a CTO case and sort of doing it successfully by virtue of chance. You want to have a reproducible structure and system in place. So what you really want to do is a program. If you want to expand that, doing chip cases also does not equate to having a chip program in place. So you really need to ask yourself a number of questions. Are you passionate? Are you flexible, willing to unlearn some techniques and learn new techniques? Are you persistent? That does not mean necessarily patient, but are you persistent and will do what it takes to achieve what is best for the patient? And you obviously, this is a field that is more humbling than perhaps any other field in the coronary intervention arena. You will fail. I assure you, in my institution, my failure rate is much higher than my colleagues who are not doing CTOs. And if the answer is yes, the reassuring thing is from all those large registries, be it the Euro PCR, Recharge, Open CTO, and Progress CTO, the success rate you will expect to achieve is anywhere between 85 and 90%, which is quite good in such a patient cohort, especially if you compare that to data from the NCDR. These are non-CTO centers where the success rate was only 5.9, with double the rate of major adverse complications compared to non-CTO PCI. So the clue here is the willingness to go through a rigorous training and continuous education program. And this is how your sort of regular CTO operator stages that they go through during the training. We start with antegrade wire escalation, master that. start with the safer type of ADR, which is antegrade dissection re-entry, then go to the retrograde side via safer collaterals, which is septal collaterals and bypass grafts, and lastly, retrograde via epicardial collaterals, which represent the riskiest type of collaterals. We actually do have data to support that proctorship does increase significantly your chances of success. So this is pre-proctorship versus post-proctorship, and you can see how proctorship increases the likelihood of success significantly, including shifting to the retrograde side. So again, this is a very rich community. You will have plenty of sources for continuous education and exchange of expertise. I think one meeting that is coming up next week is CTO Essentials in Istanbul. And Omar has put a fantastic program together. I do urge you to join the meeting, but this is just one of the meetings, and there are plenty around the year. But there are many workshops and seminars. There are also self-education material that you can go, and this is just some of the examples of excellent textbooks, but also online communities that you can join and see a lot of cases and a lot of discussions. Obviously, this is a highly technical and demanding procedure, and similar to other technical procedures, you will expect your success rate to increase significantly as your annual volume increases. Similarly, your complications rate will drop. So this is not the type of procedure that you want to do if you're doing sort of a center that is doing 200 or 300 PCIs a year and you're only doing 10 CTOs. You will hit a plateau very early on. So these are probably meant for larger institutions with a big PCI volume in general and a big CTO PCI volume in particular. Now, given that this is a field where the complication rate is higher than what you would expect elsewhere, you want to make sure that you are continuously improving your outcomes, and audit and continuous quality improvement is really the only way to do so. I will jump those slides for the sake of time, but one thing that can help is joining bigger registries whereby you can have benchmarks to compare against. So this is the Progress CTO registry, of which our center is part of, but also Omar and Nadal, who together we've also formed the Progress CTO Minata, which is the Middle East, North Africa, Turkey, and Asia subsection of Progress CTO. And we've already in the process of adding more centers in the region. I think they're just above 9 in Turkey now, 2 in Lebanon, and 4 centers coming up in Egypt. The last thing in terms of guiding principles is you do invest a lot of time and effort and cost in revascularizing those patients. So the last thing you want to do is really end up with a lousy stenting technique. So you want to pay a lot of attention and do those stenting. So you've done with the difficult part of the procedure. You have a wire in the distal true lumen, you've dilated the vessel, and now is the time to stent. You really want to do that optimally. And we think that the best way to do that is to use intravascular imaging. So it will give you guidance on where exactly to stent, whether your stents are fully expanded, whether there's a lot of calcification and you might want to consider rotational atherectomy or orbital atherectomy or shockwave or whatever. But using intravascular ultrasound in this complex subset of patients has been shown to improve both major adverse cardiovascular events as well as target vessel revascularization on both the short and long terms. And this is a study from South Korea, a retrograde analysis of 10,000 patients with complex anatomy, be it CTOs, left main bifurcations, or extensive calcification. And you can see that the incidence of cardiac death, stent thrombosis, and ischemia-driven target lesion revascularization was decreased dramatically with the use of intravascular imaging. So I think you get a lot of rewards with sticking to those 7 principles. Essentially, you will be able to serve more deserving candidates. You will enhance your technical skills and overall competence, which goes beyond the CTO arena. This is just one example in a very odd application where a very young patient presented with an aneurysm, a huge aneurysm of both the LED and right coronary artery, failed recanalization elsewhere, and presented to us after 2 months. and we were able to recanalize that retrogradely, shift to the antegrade route, and deliver a covered stent. But anyway, so you will utilize a lot of those techniques in different complex subset of patients, but I assure you that boosting your ego is not part of this, of CTO PCI, and generating income, at least in the early years, is not one of the rewards you would expect. As we treat sicker and older patients, you obviously are encountering this sort of pyramid step by step. So you start with physiologic assessment, simple focal lesions, start experimenting with 2 wires, simple bifurcations, then get into left main PCI, rotational atherectomy, and CTO PCI really belongs at the end of the pyramid. So if you plan to or want to have a CTO PCI program, it is highly advisable that your center is already established in those other areas. So for the sake of time, I will stop here, and thank you very much. And if there are any questions, I'll be happy to answer.
Excellent talk, Ahmet. Thank you very much. Really, you touch everything regarding CTO. How can we start? How can we build a program? You touch everything. Thank you very much. Can we have any question from audience, or we have a Q&A here, but we don't have anything from the participant. If we have, I think we can have their question as well to discuss. I think, regarding to start CTO, in my opinion, anyone, who moderate level for PCI can start CTO, because CTO has, score. Someone may not do or cannot do very, complex CTO, but at least they can do up to CTO score 2, for example. And if someone does, some tips and tricks of CTO, or at least they know, to learn wires, microcatheters, some technique like parallel wire technique, or wire escalation technique, those basic techniques. If someone learned that, to me, I think 7 to 75 of patients can be treated by, moderate level operators. That's my opinion. Because now we have, excellent wires, right? We have very good wires, but we have also lots of wires. If someone start to do CTO, I recommend that choose some wires, 1 or 2 hydrophilic wire, 1 or 2 stiff wire, 1 or 2 for red-to-red wire, and also 1 or 2, not more, microcatheter. It's nice to have, less type of things in the shelf, I think. So, but to start CTO, we have to have discipline in the cath lab. That's very important, because we should check ACT, more often than other PCI. That's very important. We have to check ACT, every 20 minutes, for example. And also we have to have definitely technicians and nurses support, to do CTO cases, because CTO cases take longer time. Preparation takes, half an hour. As you mentioned, Ahmet, we have to review angio, at least 10 minutes, at least 10 minutes we have to review angio. We have to see bilateral injections. We have to decide which collateral is good and which is better. And we have to see antegrade, approach, antegrade cap, distal, channel, everything. So, we have to have good discipline in the cath lab. We have to good relations with our staff, nurses and technicians. They can help us, or they can try to paralyze us. So we have to be very careful, and we have to have them with us. That's very important for a new beginner for CTO, I think. Yes.
I actually like your comment, because you touched a real problem in the perspective of a beginner. I know a lot of beginners that have a passion to start CTOs, and they have a real problem because they are confused about how to set the program, how to start the learning curve between the guidelines that they are recommending that they have to have a certain volume. Of course, in their beginning of their career, they have not a tenth of this volume to get along with the learning curve. So they have a real problem in learning. They have the passion. They are attending conferences. They are attending meetings like we are doing now. They are reading a lot of tips and tricks and so, but on the real life, on the CAS lab, they need a real help with a real program involving, like Dr. Ahmed said, a good cooperation with the more experienced doctors. And this is really, yes, it's for example, in Egypt, it has been occurring in the last few years, thanks for an expert of CTOs like Dr. Ahmed Kendi or Dr. Tariq Rashid and others who are dedicating themselves almost mainly for CTOs, and they are going around different places in Egypt, trying to help others with less experience. But still, there is no established program, and there is no system of proctorship. I mean, how the beginner can really start is a real difficulty. And you touched the point that he can even by classification of the difficulty of CTOs, there is a chance that he can start with simple cases or then a moderate and so on. But we really need to cooperate together in helping young individuals, because this is a problem not only in Egypt, maybe in Turkey as well, and worldwide. And number of CTOs are growing. So we are. I just want to touch this problem, and you get some of its answer, Dr. Amar.
No, I think I just want to sort of clarify to the audience two different things.
Yeah.
And one is CTO PCI. Luckily, there is hardly any emergency CTO, so there is always the room. And this covers what Omar said and what you said, that you can always plan ahead and say, okay, this is a case I need some help on, and this is a case I can take on my own. However, the discipline part is extremely important for the setup. So you cannot cut corners when it comes to not having an ACT in your lab. You cannot cut corners if you have a single cath lab in your hospital and you're doing primary PCIs, for instance, and you're blocked with a CTO that can go for 3 or 4 hours. So there are certain things that you can accept the early experience with what comes with it, but there are certain things when it comes to the discipline of the team, the infrastructure that can support this type of procedure, which you really can't jeopardize. As for the volumes, I think, again, this is the added advantage of not having this as an emergency procedure as such. So you can always plan in advance. But my advice to fellows nowadays, if you want to do CTO PCI, this is relatively different than what we used to say 6 or 7 years ago. You can have an anti-grade only operator and they don't really have to do retrogrades. Yes, you can do that at this time in your training, but optimally or ideally, if you want to become a CTO operator, you really want to master all the techniques. So you can accept I'm doing anti-grades only for the time being. But if you really want to establish a CTO program, you want to make sure that the program as a whole, not particularly the individual, is able to address all or have all the approaches under their belt. So I think it's
Ahmed,
yes,
I think we can differentiate between, you know, CTO operator and expert CTO operator. Yes, CTO operator, you know, mainly focus on anti-growth approach. You know, they can do retrograde if they have a nice collateral. But when we talk about the expert CTO operators, that's different. It means that they could do very tough cases. I think we can, you know, and most of the time when we talk about expert CTO operators, it means that they are proctoring. So their main job is CTO, right? So, but many moderate intervention cadres, I think, can be CTO operator. I believe that. But
absolutely agree.
They have to have power, you know, in their hospital to reach, you know, materials, you know, to design the cat labs. For example, if they don't have any power, they will do nothing, right? They may, they can, you know, they may have, you know, knowledge, everything, but if they don't have power, if they can't reach the materials, they cannot do CTO. So, and also I suggest some, you know, senior colleagues who they don't do CTO. I encourage them to do CTO because they have, you know, they have patients in their lab, in their, you know, city. They have power in their hospital. I think this is job a little bit for, to be honest with you, senior interventionalists, not the fresh one. That's my thinking. That's big mistake. Very young, you know, colleagues try to learn CTO. They come to us or they go to other places. When they back to home, if they don't, you know, have access to rich materials, they can't do anything. That's also important.
Partnering with a more senior colleague, even if he is not a CTO operator as such, brings a lot of power in the hospital in terms of politics and securing the consumables and the time for the cath lab and the resources, but also with a lot of wisdom in terms of judgment and overall decision making. But this is definitely not something for a novice operator. You need to be a solid operator with complex PCI in general. Now, for the sake of time, and speaking of people with a lot of experience and pioneers in the field in Egypt, I'm happy that the next speaker is going to be Dr. Sharif Al-Biltagi, one of the pioneers of CTO PCI in Egypt. And as a matter of fact, I think he was already doing CTO PCIs when I was learning all about guide catheters and wires to start with. And this is not to make him look old, but it just gives you a lot, years and years of experience for someone who has done a lot for the field. Dr. Sharif will be presenting a case on anti-grade wire escalation and sort of take us step by step. And please do step in with any questions during the talk. Dr. Sharif.
Thank you very much, Dr. Ahmed, for these nice words. Actually, I'm doing CTOs since a long time, but honestly speaking, I'm still learning a lot, and I'm particularly learning from those who are really, for me, an expert for CTOs, especially in Egypt and also in the Middle East. Whether I learn from them in conferences or in real life, and I sometimes again call them for help to work with me in cases live. And I thank for this generation actually that they are spreading the knowledge and the technique of the real contemporary CTO, which I'm trying to reach some of their experience in it. Anyway, I will not waste time. I will go directly to our patient here. He's a 55 years old electrician with hypertension and hyperlipidemia as a risk factors. He has an inferior MRI 8 months before that was treated conservatively. And then he remained with angina class 2, refusing to make angio. And his ejection fraction is almost preserved with a large inferior hypokinesia. His coronary angiography, at last he's convinced to do an angiography which showed the left system free of significant disease with brisk collaterals filling the distal RCA, which has a long proximal to mid-lung CTO, as you will see. As Dr. Ahmed wonderfully demonstrated and stressed about the dual injection is a must in any case with a contralateral injection. And it's not only important during the procedure to see the distal wire or so, but it's very, very important before the procedure in the careful assessment of the angiography, because it's more accurately can assess many factors that is crucial for the planning. For example, the lesion length and the distal cap and the distal vessel could not be accurately assessed except by dual injection. As you see, our CTO is a rather long RCA CTO with a good collaterals, not shown here because they need special views. I'm sorry, it's not available here from the left system, but I remember there were multiple of sizable septals filling the distal RCA. The stump, as you see, is rather, it's not I couldn't call it ambiguous, but it is a blunt, at least blunt stump with perfectly flush with sizable conus branch, as you see. And the lesion length is sure, it seems to me it's sure to be more than 20 millimeters. So as Dr. Omar and Dr. Ahmed mentioned, evaluating the diagnostic angiogram, I'm always calling it the pre-CTO meeting with all my CAT lab staff attending. There are many factors important to determine, mainly 4 factors, but others as well. We'll not waste the time in it. We all know it, but at least we here see, as I said, the proximal cap is not very well tapered. The lesion length is more than 20 millimeters. The collaterals, although not seen, but they look very attractive intervention collaterals, septals. And the quality of the target vessel, which is very important in decision as well, looks to be reasonable, although we know that it's always underestimated due to under perfusion from collaterals. We all know that one of the strong predictors of failure in the CTO PCI is calcification and severe tortuosity of the vessel. And both actually can be easily detected by pre-procedure CT angio. For example, if we get to our case, the long occluded segment can be like that, or can be tortuous like that. And it makes a hell of a difference during wiring. So a pre-CTA angio is very useful in showing the cause and resolves the ambiguity of the CTO segment, as well as showing also the degree of calcification within this segment. We are using.
Thank you, Dr. Sharif. Can I stop you at this stage?
Sure.
Sorry, after having reviewed the angiogram, just for discussion purposes,
Okay.
and start with Omar. So the first question I have for Omar is, how often do you do CTs for your patients nowadays? And the second question is, how would you tackle this patient with this anatomy before we go to Dr. Sharif and see how he sorted it out? Omar, can you unmute yourself, please?
Ahmet, yes, we have CT in our hospital. I mean, we do our CT in our hospital. So we use CT a lot for CTO procedures, especially we have difficult case, complex case. We do CT before CT operation. And if it is failed case, it's if it is our failed case, or if is from someone who is who is CT operator, then we do CT angio. I think it's very helpful. For example, in this case, after CT angio, now we know that that vessel is straight, and now we can see the proximal cap after CT angio, and we see that there is not that much calcium. There is calcium, but they are not that much. There is no block calcium, at least. So it's very helpful, especially here. You see that that vessel is it's not that much tortuous to me. That's fine. So, and also, in this patient, when you see from the LAO, it looks like there's an ambiguous cap. But sometimes, oftenly, if you go from the RC right oblique view, then you will see, you will at least you will guess where is the proximal cap. So it's very important. For example, for this patient, it's very important to see from the right oblique view. Sometimes I can see easily where is the cap. Although in this view, RC LAO view, it looks like ambiguous cap. If you look from the other view, you can see or you can guess the proximal cap. To me, I can't say it's ambiguous cap if I know where is the cap. Sometimes we can't see it, but we know it, right? Where is the proximal cap?
So with this anatomy in mind, Omar, and the data you have from the CT, what would be your primary approach here?
Okay, and here, in this, according to the CT, the first wire of me would be Gaia second or third, Ahmed.
So you would go antegrade first, now that you understand where the proximal cap is exactly. And
yes. In any way, I try first, because sometimes, our wire can find proximal cap as well. So, sometimes we should give a chance for our wire if they could find a proximal cap.
Very good. Tariq, are you with us? Dr. Nabil just joined in. I'm not sure if you've seen the case. Great to have you on board.
I'm sorry. I will close my phone first.
Okay. Okay, so perhaps we wait till we review the angio for the second case. And Tariq, are you with us?
I joined late, Ahmed. I'm sorry. I just finished the case.
I saw you in the car. Thank you for joining in so quickly.
Thank you very much.
Tariq Rashid, are you on board?
So I have a problem in the cath lab, so I'm not concentrating on the case. Just I have a case with perforation. I'm sorry.
So okay, so don't let us waste your time. Just let us know when you're fine. I hope all goes well. It's a busy day for everyone. We won't keep you. Thank you, Tariq. Khalid, so how would you? I hope you've seen the case from the beginning, and what would be your primary approach? Khalid Mandoor is also with us.
I think I'm going to use a Gaia second on a microcatheter from the beginning.
Okay, so antegrade with a Gaia second.
Yeah.
And I think that's a very good thing. Perhaps I'm glad that Dr. Sharif showed the case with the CT, because indeed, now with the data from the CT, you have a clearer understanding of the vessel course. Some cath labs have co-registration with CT, so you can actually put the same angulation, simultaneously understand the vessel course and overlay it with the image you're getting on the fluoro screen. Otherwise, you can simply put it in the same angulation that we derive from the CT beforehand, and we do that in 2 different projections. But I guess, yes, in this particular occasion, the CT gave you a very clear idea, and antigrade becomes a possibility. Otherwise, without the CT data, I would probably have been tempted to either go for an antigrade dissection re-entry and let a knuckle resolve the course ambiguity, or go retrograde from the outset. But that's the info we're getting. We're eager to see how Dr. Sharif actually treated the case. Dr. Sharif?
A small comment, Ahmed. I would like to add a small comment.
Yes, please.
Yes, CT is very important to know the course of the artery. But as you said, if you don't have this CT before the intervention, and you don't know the artery whether tortuous or not, in this situation you can use the knuckle technique, as you said, Ahmed. So either you use the CT to know the course, or if you don't know, you can use a knuckle technique in this case.
Yes, Ahmed, but before starting knuckle technique, why don't we try, the wire with like XT or pilots, 200, just, to search the proximal cap. Sometimes, if you think that Gaia second is a little bit stiff, then we can try Fielder XT. Sometimes Fielder XT goes directly cap, right? Proximal cap, and especially from the right oblique view. I think for me, in this case, before starting knuckling, which end up with the ADR mostly, I like to do that.
Excellent point, Omar. So Omar is pointing to us. Yes, the answer is we usually try a tapered polymer jacketed wire first. And even if you go for a stiffer polymer jacketed wire like the Pilot 200, if your XT is not going, we actually try to sort of explore the proximal cap and the body of the CTO. And only when we get stuck do we knuckle. But the important message here, if you do not understand the course of the vessel, a polymer jacketed wire is always safer. Now, this is probing with a polymer jacketed wire, not a knuckle, because they will tend to stay within the vessel architecture. Now, this is not true with a Gaia second or third or a Conquest Pro, where you really need to understand the course, because you can easily perforate and exit the vessel architecture indeed. So what Omar is saying is extremely important. If you don't understand the course and you want to explore with your tip of the wire, a polymer jacketed wire is the safer way of doing that, because even if you don't end up going true to true, you're most likely to remain within the vessel architecture itself. Thank you, Omar. Dr. Sharif?
Yes. So I'll continue from here. I was talking about the using scores, and the most famous, as you know, is the JCTO scores. Actually, we use them a lot in meetings and in presentations, and we are using them much less in real practice. Although I believe they are very useful in determining the difficulty of the case, especially for beginners and fellows. So I encourage them to use a lot scores. Here, the CTO score is 2, which shows it's a moderately difficult case. Also, the progress CTO score much less used than the other one, mainly in the US, and adding, as you know, 2 more factors like the intervention collaterals and the circumflex CTO as more points of difficulty. I also encourage fellows and all operators actually to use the complication score to assess the risk of the case. I believe it's important. Here, as you see, the progress complication score emphasizes the importance of the age above 65 in increasing the risk, as well as the lesion length, of course, and the retrograde approach. And as you know, it's a retrograde approach have a less success rate and more complication rate than the antigrade approach. This is one of the reasons, actually, we decided in this case to start with antigrade. And antigrade wire escalation you will say which wire to start with. Actually, this is different among operators, but the most common scenarios or orders of wires used worldwide these days are in this order, starting with a Fielder XT, then the Gaia family or a Pilot family, Pilot 200, and then to the Confianza family. And this is, as you know, is a contrast to what we used to do more than 10 years, before 10 years ago. It was, we used to make it incremental increase in stiffness, but this has changed in the contemporary CTO era. And this is one of the algorithms to help you to choose which wire to start with. As you see, Fielder XT, then stiff tapered wire like the Gaia or Confianza. If the course is known, if the course is not known, you may use the stiff polymer jacket wire as Dr. Ahmed Al-Gendi just mentioned. Anyway, most start with the Fielder XT, and because of the wonderful discovery more than 12 or 13 years ago of the micro channels, which are present in many CTO segments, even if they are not visible and geography. Actually, the Fielder XT has changed the practice of most of us. But I started here with the Fielder XT, but actually it couldn't penetrate the cap, and even after wedging the fine cross in the occlusion, it couldn't penetrate, always prolapse into the conus band. So I didn't waste time, and I decided to get a more stiffer wire to try to puncture the cap. And I used here a Pilot 150.
Sheriff, do you have
yeah.
the weave from the right oblique? Because sometimes
I liked your comment about the right oblique. The right oblique is always forgotten in the right coronary artery. You say you are right. It may show the cap, and retrospect, when I reviewed the case, I could find a bit of a stump in the other view, and that explained why the Pilot gets easily puncture of the cap. Absolutely right, Omar. In no time, I could direct the Pilot 150, and it punctured the cap easily. And I can, at this stage, proceed my microcaster and change for a Fielder to be more safe crossing of the long CTO segment. But anyway, I remained manipulating because I found actually the Pilot is doing a good job and could be slided or drilled easily through the occlusion, proceeding rather fast in a fashion of between sliding and drilling, a bit of a modest controlled drilling. And when I say controlled drilling, I mean a rotation in both directions within the 90-degree limit, because actually too much rotation, as you know, frequently leads to subinterval space. So this is very important for fellows to remember during drilling. Anyway, the Pilot actually remained proceeding, and at the time I have to advance my microcaster to help support a bit. And although I'm not rotating vigorously, I mean with a gentle rotation and drilling, it reached the distal cap, but unfortunately, with a very careful frame by frame contralateral injection, I discovered that it is entering the subinterval space, not the real true human. So this is a very important point, as you know, in anti-grade wire escalation. When you reach the distal cap and you have to puncture it into the true lumen instead of the subinterval space, because it will make a lot of difference in the procedure further. So what do you do next, Dr. Omar? Can you tell us in this situation when you have a pilot 150 or 200 at the distal cap, but entering the subinterval space, what options you have at this moment?
Okay, yes, very good case, Sheriff, very good case. You know, we see that how pilot 200 punctured the cap and then goes through the vessel. At least it stays in the vessel, in the architecture. So since your wire is you know, hydrophilic wire 200, it's not easy to redirect that wire, right? You can pull it back, but not easy to redirect and to find some other place with this wire. In this case, if it goes in the true lumen, fine. But if it goes subintimal, mostly I leave that wire in place and I send another wire. Now I have, you know, now I know where is the proximal cap. I know the course of the vessel now, and also my first wire, little bit straight, uh, make more straight the vessel. So in this case, my second choice would be Gaia second. Why? Because I just need to go a little bit parallel to first wire. At the distal, I can redirect my Gaia second where I want. Mostly, I can torque it easily in the vessel. So I think Gaia second would be a good choice. And also, we have one question from the attendees, which is very good question. I think it's comment. She says that Fatma Fat El Bab. She said that IWOS also could help. Yes, that's a very good point. We should mention that IWOS can also help. But side branch is a little bit small. I don't know if we insert that side branch IWOS catheter, but most of the time we can see where is the proximal cap with IWOS. That's I think we should mention it in the ambiguous proximal cap.
Yeah.
So excellent question from Fatma. Indeed, you can use IVUS to resolve the ambiguity of the cap, not the track per se, because you won't see the track as such. But yes, perhaps the side branch isn't indeed a bit too small. I see Muhammad Atif on the panel as well. Thank you, Muhammad, for joining. So Omar, obviously at this stage, his option would be to leave the pilot 200 in the subintimal or the subadventitial plane and re-advance the microcatheter. So essentially a parallel wire with a more torqueable wire, the Gaia second. What would be your next course of action? Muhammad, you need to unmute yourself.
Can you hear me clearly right now, Ahmed?
Yes. Perfect. Yeah.
That's great. Okay. Yes, I like the option that Omar previously said. I will go with the same scenario. I like the case, as you said before, Dr. Sharif. Actually, this is a common pitfall. We have, me myself had twice or a third time, maybe the same problem. The wire just goes easily, and when it comes to the distal cap, you just find that you are not in the true lumen. For me, actually, yes, I go with the wire that I can rotate easily. I like the Gaia family, so I totally agree with just Omar said. I will leave that wire in place and we'll try another wire and go for Gaia second for sure.
Excellent. For the interest of time, anyone from the panel, Dr. Nabil, Khalid,
yes,
Tariq,
Ahmed, I can add
anyone do something different?
Yes, a parallel wire technique is a very good option in this case, and I think we can use a dual lumen microcatheter just to help directing the second wire into the true lumen. This is one option. I used it several times, and I went sub-intimal, and it was actually successful in directing the second wire into the true lumen. It is some sort of a double wire technique, but using a dual lumen microcatheter.
Excellent point. Had I opened a dual lumen microcatheter initially, if, for instance, penetrating the proximal cap was difficult, and I needed a dual lumen, I would definitely use it for a parallel wire technique, because it does indeed give you the room. A, it will straighten the vessel even more. B, it will block the entry into that subadventitial plane with the Pilot 200, and it will give you an excellent torque control and base of operations for your second wire. And as a matter of fact, you can even change if your Gaia second, for instance, doesn't work. So yes, a dual
Can I have
lumen.
another comment, Ahmed?
Yes.
Would you pull back the wire and try Stingray and try to recross with another wire?
That would be Clan C, and it really depends whether you have it on shelf or you have the expertise. So I would do a dual lumen assisted parallel wiring, and if I still end up in the subintimal space after 2-3 minutes of trial, so as not to increase the subintimal hematoma, I would shift straight away to an ADR. But then again, it depends on whether you have it on your shelf and you have the experience. But for me, that would be the third choice. If that doesn't work, the fourth choice would be going retrograde. Dr. Sharif, sorry we keep interrupting, but it's obviously.
No, I'm really enjoying these comments, because as you see the next slide, which shows the different options you have, you are already all discussed. You have an option.
I want to ask you something.
Sure.
It was easy to insert microcatheter over the Pilot 200, or
Yes.
it was easy to
Fine
insert.
cross, so easy.
Okay.
Yeah.
That's important, because then you can use double lumen catheter,
Yeah.
as parallel wire technique. If not, I don't think double lumen catheter is option. So we should know that if it goes easily or not. That's important.
Oh, that's a good point. Anyway, you have many options in this situation, which is rather a common situation. You could use a knuckle, and as you know, you can knuckle even the Pilot itself, although it used to, as you know, make a larger knuckle than the Fielder XT, which you can even replace the Pilot with a Fielder XT and do a knuckle with it. You can do a wire-based re-entry, and increasing the band of the wire, or a more stiffer wire to enter into the true lumen. Or as you discussed, I think it's the last choice to shift to a device-based re-entry like Stingray, or simply use the parallel wire technique, whether using it with a single microcaster or two microcasters, or preferably, I think, I agree with you, preferably with a dual lumen microcaster. In this case, actually, of course, the rationale of the parallel wire technique. Just leave the wire in the subinterval space, get another wire over. Of course, you remove your microcaster and put it on this new wire, and try to get advantage of the first wire, which acts as a marker for the subinterval space. You can avoid the subinterval space with no contrast or less contrast, and you also get advantage that the wire may block the entry to the subinterval space. But just remind yourself that you have to work early or a bit more proximal with the second wire in order to have a new pass and to avoid the same pass like the first wire. And remember also not to rotate a lot to avoid wrapping of the wire, of the second wire over the first wire. The first wire also sometimes may help in straightening the vessel, helping the second wire to get into lumen, especially in tortuous or curvy segments. What second wire to get? It's open to discussion, but anyway, most of you actually choosing what I have chosen, the Gaia second. It's a very torqueable wire, and actually I was missing torqueability here with the Pilot, and it's also more stiff. Usually it's use the second wire at the same stiffness or more stiffness than the first one. As you see here, the Gaia second actually did a marvelous job. It's entered in the through lumen, and you have to be very careful. As you know, you make an orthogonal views and even zooming and frame by frame in order to be sure that the tip of the wire is not again puncturing another subinterval or in the same subinterval like the first one. And as you see here, there is a nasty curve just after the distal cap and taken beautifully by the Gaia wire, Gaia second. And then we could advance the wire in the distal RCA easily, passing the microcaster distally and changing with the workhorse wire as usual. And then the rest is as per standard in PCI, pre-dilatation, stenting, post-dilatation. And stress here for the again to not to neglect post-dilatation. It's very important for the long-term results actually after doing CTOs. And I was lucky actually to end with this result.
Sharif, can I ask you a question just before you finish?
Please go ahead.
You crossed with the Gaia wire to the true lumen, and this is very good. And the balloon pass looks to be an easy passage of the balloon. What would you do if there was a difficulty? The lesion was long and it was calcified. And what options do you have if you were not able to cross with the balloon after crossing with the wire?
It's a very good question for a very common situation. Uncrossable or difficulty in crossing your gear after passing the wire. Actually, if you remember at the beginning of the case, one of the important points in evaluating the angiogram is the side branch before the occlusion. And there was a sizable conus just flushed with the stump, as you remember. And this is, I kept an eye on this, very important, because I may use it in anchoring. That's one of the options. It's very helpful. Very simple step. Otherwise, especially if you observe, I used here a right Judkins, and I rarely do that in CTO RCA. Usually I used Amplats, left guiding. I don't know what was the reason at this case, but anyway, you have also other options of increasing guide support by guide liner. If the anchor is not enough, and if the guide liner would not give you that support, you can of course use a rotablator as a last choice if nothing is working.
Sharif, very good case. I like your technique, and I would do this case exactly same as you. I think this case is very good example. I like to push and encourage non-CT operator to do CTO cases. For example, to me, any or moderate interventional cardiologist can do this case, right? If they know how to use microcatheter, if they know the wires, pilot series and Gaia series on some other wires, I think they can do that. They can send one wire. If it is subintima, they can leave it and they can try to send another wire, right? So if the second wire again in the subintima, that's another story. It means that this case is a little bit difficult. Either you should go retrograde or do something else like a Stingray or knuckle wire again, like Ministar. But those techniques are more expert techniques. So someone at least can try one wire. If it is in subintima, try second wire. If it is still subintima, then they can leave the case. They can call it failure, but I'm sure they open at least 70-75% of cases. So I think, you know, we should push our colleagues to do CTO cases, to be honest with you. This is not case for CTO operators, you know, expert CTO operators. This case should be done in many operators, I believe. What do you think?
Absolutely.
What's your opinion? Yeah.
Yeah, 100%. This is to encourage actually more operators to do CTOs, and as you said, as we mentioned before, we can assess the difficulty, and in easy or moderately difficult cases, we can encourage more. We need actually more CTO operators. There are a lot of CTO cases, and they are medically treated or going to cabbage. So we actually in a bad need for more CTO operators. And that's, I like also the point of stressing on a parallel wire technique, because this technique is an old technique, as you know, and has been underused lately a lot, especially by experts, because they prefer to do re-entry techniques and so. But I believe it's still working, and I believe beginners or fellows should use the parallel wire techniques. For this, I can, Dr. Omar, Dr. Ahmed, and my dear colleagues, get a final thoughts from this case that reviewing the angiogram is very important, because we have to consider CTA, CT angio before the procedure in most of the cases. Dual injection, of course, is a must. We have to know the properties of each CTO wire, as Omar said. We have to efficiently work through wires based on anatomy. And regarding the parallel wire technique, I believe is still valid and still useful technique in an anti-grade wire escalation. The wires most commonly used as a second wire are stiff and highly torqueable wires such as the Gaia and the Confianza Pro 12. Some tips and tricks is regarding the parallel wire techniques. Rotation of the second wire should be limited to minimize the wrapping or the chance of wrapping around the first wire. Early redirection of the second wire within the CTO segment is important to create a new pathway. The tip of the second guide wire may require more acute bend to find the distal true lumen. And finally, use of orthogonal angiographic views. Thank you very much.
Thank you, Dr. Sharif, for an excellent case with an excellent result. I'm really glad that you were able to show a parallel wire technique, because you're quite right. This is one of the older techniques. It was a bit of a turn-off that in the Western hybrid algorithm, at some point in time, it was completely removed as one of the viable techniques. I think this was very aggressive to consider only ADR as the option if you have a wire in the subintimate space. But I'm glad that the Asian algorithm years later, and more recently the European algorithm, do have a specific entity for parallel wiring. I think he showed beautifully some sort of guiding principles for parallel wire technique. Essentially, your second wire probably has to be a bit stiffer, otherwise you'll follow the exact same trajectory with the first wire. It has to be highly torqueable, and the use of orthogonal views is absolutely mandatory, because you want your wire to overlap exactly with your older wire or your first wire in one view, and separate in the second view where you find yourself in the subintimate plane. This is an excellent demonstration of a technique that is, at least some people push to abandon it, but we've seen that how extremely efficient, cost-effective, and as you and Omar mentioned, can be used by less experienced operators and end up with a beautiful result. Now we have a quick comment from Dr. Fatma. With laser, I think excimer laser for balloon uncrossable lesions, the answer is yes, but excimer laser in particular is not widely available. There are other techniques Dr. Sharif has talked about increasing support either passively or actively, but we also have a number of other maneuvers. You can rupture a balloon, what we call granuloplasty, wedged within the catheter, within the CTO body. You can obviously try using a smaller balloon, and when the Sapphire 1.0 and more recently 0.8 millimeter balloons have an excellent crossing profile. You can deliberately go subintimal and crush the cap from the outside. You can shift to a retrograde approach, but there are essentially many different ways you can go subintimal and go and do an ADR. But I think laser does belong, but probably at the very end of the solutions. Now, I think we'll move to the second presenter of the day.
Can I have a quick question, Dr. Sharif?
Yes, please.
Yes, one more question, Mohammed, and for the sake of time.
A very rapid one. Dr. Sharif, good evening. As a parallel wire technique, so you're trying to pass another wire in the CTO segment. Would you like to start early as from the ostium, or just try to slide the microcatheter, and when it stops, you try to navigate another track at that point? So what you would prefer to do at this case? At which level you start to find another track?
You mean with the second wire, huh?
Yes, with the second wire.
Actually, as I mentioned, you have to try a bit early, not from the osteo, of course, but a bit early through the course of the CTO segment in order to avoid going to the same pathway of the first wire, which is a frequent happening. So you have to try to rotate your wire, second wire, of course, a bit early, and you start with a bit early and try a bit by bit in order to avoid the same pathway. I think this is a very useful tip.
Excellent question and excellent answer.
I think this is, Ahmed.
Yeah,
Mohammed, this is excellent question. Yes, for parallel wire. This is very important question. I agree with Sharif. You know, it depends on how far your wire. Yes, if it is really far from the true lumen, it's better to find, you know, it's better to puncture at the beginning differently, right? If it's your first wire is very far. If it is close, 1 millimeter, 1/2 millimeter, of course, it's, you know, very logical to go very close to first wire and then move 1 or 2 millimeter to do the other side. Yes, that's the technique. But if it is very far, it's better to puncture differently at the beginning, especially if you don't know where is the cap. Sometimes we puncture, you know, very far at the beginning, right? It's better to do puncture in another place. But this question is very important question for parallel wire technique. Thank you for.
We'll add one comment. Yeah, we need to remember that parallel wiring is not a re-entry technique. It's essentially meant to go for true to true. So this is further emphasizing both Dr. Sharif's and Dr. Omar's reply. You aim to go true to true with parallel wiring rather than go into the same subintimal space and try to re-enter, because that is not the main essence of parallel wiring at the very least. Now, Tariq, I see you've shared your screen, so I assume your patient is all right. Tariq, unless someone else is using your laptop and sharing the screen.
Yes.
Tariq, are you with us?
He has to unmute his.
I'm with you, Ahmed.
Yeah.
Started sharing screen. If you can see my screen now.
Yes, so everything good your end? I already have a backup for your case. Okay, so this is important. We already have a backup for your case, just in case you need to be in the cath lab. So are you fully comfortable to start?
Okay, no problem. I'm ready now. Okay.
Okay.
Yes, I'm ready, Ahmed. I can start now. You can hear me?
Okay.
Okay. So yes. It's my talk today about the ADR. I selected some short cases, or not a single case, with some data on this technique. So if you are talking about the ADR comes from the initially from the use of the subintimal space as an easy space to move through by equipment rather than moving through the intimal space. And first described by the STAR technique, which uses the subintimal tracking and re-entry at a side branch. Of course, you have to avoid forming a hematoma in the subintimal space. If you are looking to this algorithm for the Asia Pacific for CTO crossing, so you will find that almost always the ADR comes as a bit out technique, or the last technique if you fail to use the anti-grade wire escalation and you didn't find a good interventional collateral, so you don't have a good retrograde option, and at the same time you fail to cross from true to true, either after using imaging, intravascular imaging, or by wire escalation technique. And usually this comes with the ambiguous course of the vessels, with the tortuous CTOs and the heavily calcified CTOs, with long occlusions, and of course with the previously failed attempts. So if you are looking for this, you will find that the ADR comes at the end, and this is a roadmap for the ADR. Usually, if you don't have a good interventional collateral, and preferably, or you should have a good landing zone, and this is found in the calcified and tortuous CTOs. And if you are not well trained to use an IVUS guidance for puncturing the proximal cap, as I said in the beginning, preferably as a bail-out technique. So we have different techniques to use the subintimal space. First two of them are the STAR and the contrast-guided STAR, and both techniques usually are aggressive using of the subintimal space till find a large side branch and trying to re-enter at this large side branch. And they have both have the disadvantage of long subintimal course and losing a lot of branches. The third and fourth techniques usually required assisted devices, either in the mini-star using the crossboss and Stingray, and if you are using the IVUS guidance with a penetrative wire, this is the limited anti-grade subintimal tracking. So if you are going to use this technique in the long and complex CTOs with lack of appropriate collaterals, first you have to do a dissection plane, then manage yourself in the subintimal space by trying to avoid over manipulation in the subintimal space, trying to be a little bit closer to the distal trullium, and avoid aggressive manipulation, avoid injection in the anti-grade guidance, try to do a blunt dissection, and then you will try to do a re-entry by either any of the techniques. So if you fail to do a re-entry, you will need a device-assisted re-entry, which is the Stingray balloon. If we look for the data from registries, we can find that almost always this technique used in the complex CTOs and with high JCTO score, either in the EuroCTO or other registries, you will find that this technique comes with a high JCTO score. And if you are going to the steps of doing this technique, you will start by first scratching or engagement in the proximal cap by a stiff wire, then advancing your microcatheter and pushing a polymer jacket wire by its knuckle through the vessel course, and this is called a scratch and go. If you fail to scratch the proximal cap by a stiff wire, you may use the other technique, which is the base technique, with using a one-to-one balloon inflation in the proximal vessel and moving the cap more proximal to the actual cap, and enter the subintimal space proximal to the cap and do your technique according to the situation. So this is the formation of the knuckle. First, you will make an umbrella-shaped curve in the distal part of the polymer jacket wire, and pushing this wire, soft polymeric wire first, you have to try, and pushing this wire by its shoulder through the subintimal space. This will allow you to align the vessel course without puncturing the vessel architecture into the outside of the vessel, and try to avoid large knuckles, as this will increase the trauma of the subintimal space, compress the distal trullium. So you have to do an ideal knuckle, which is maximum 1:1 diameter, 1:1 size to the reference vessel diameter, and avoid the large knuckles for avoiding the hematoma. This is an example of how to do the knuckle, scratching the proximal cap on the tip of the microcatheter and advancing the microcatheter to the proximal cap, then exchanging this stiff wire by polymer jacket wires, advancing this wire by its shoulder, will move through the subintimal space and align the vessel course. This is different wires you can use, which is all of them are polymer jacket wires, and this is an example of how to do a knuckle. This is a CTO of a post-coronary artery bypass graft patient with an occluded circumflex, and scratching the proximal cap with a Gaia second wire. And if you can see that this wire, after scratching the proximal cap, going to the outside of the vessel, and this is due to the vessel tortuosity. So advancing the microcatheter again, and exchanging this Gaia third wire or Gaia second wire for a polymer jacket wire, which is the Fielder FC, and pushing this by its knuckle, you can find your way through the subintimal space to the distal vessel, and you may be lucky, as in this case, that by the tortuosity of the vessel and the heartbeats, the knuckle enter the true lumen, and this is, you have a 50-50 chance to do this, and this is the final result of doing the antegrade knuckling and stenting of this vessel by an antegrade dissection reentry. So if you are going to going to second step of this ADR, it's the re-entry, and this is the most difficult part of the procedure, how to re-enter into the distal true lumen, and how to try to avoid going through the subintimal space for a long distance, and try to make your re-entry just distal to the distal cap of the occlusion. So it's a very challenging procedure, and of course a lot of techniques described. First of them is the star technique. In this technique, you will use a long segment of the subintimal space till you reach a bifurcation, and at this bifurcation try to redirect a penetrative wire or other wires to one of both branches. And these techniques, of course, is not suitable for left anterior descending artery. It may be used in the right coronary, which is have the main branches at the distal part of the vessel. So you might use this technique in the right coronary artery, but it's not useful in other vessels like the left anterior descending with a lot of branches. And the other technique, if you are not able to push your wire through the subintimal space, so you might use a contrast guided dissection to just make a dissection in the subintimal space by contrast, and to at least see the vessel course. But of course, injection in the subintimal space is a little bit dangerous, and this will cause a hematoma in the subintimal space, compression of a part of the distal true lumen, and will make the re-entry very difficult. The third technique, which try to use only a limited dissection plane, reaching the distal cap, try to use IVAS guidance with a penetrative wire, and try to enter after crossing the distal cap by this penetrative wire under IVAS guidance. Of course, it's a very challenging procedure and require a long time and experienced operation. And at the end, all of these techniques will require a little bit of luck, experience, and time, maybe a contrast. And at the end, you might have an hematoma in the subintimal space with the distal lumen compression, and you will not be able to cross at the end. This is an example of the ADR in the circumflex. Here we have a short segment of occlusion, not a long segment, but the problem that we have a distal bifurcation and always the wire, and of course left circumflex artery is one of the ambiguous arteries in its course. So we tried by antegrade the wiring. This is a guide third wire trying to go to the true lumen of either branches, but we failed to go, and every time we are going to the subintimal space. So advancing the microcatheter in the subintimal space and getting a polymeric wire, which is the fielder FC, and doing a knuckle, and here we can enter the true lumen by the this knuckle. And at the end, we got other wires in other branches after PCI and doing stenting of all branches, and this is the final result of the this case. This is another example of a long CTO of the right coronary artery with a poor retrograde feeling from the left system or a difficult collaterals from the left system. And after trials of crossing with different collaterals, and unfortunately we have a stents in the left anterior descending artery, so we couldn't able to cross retrogradely. So we used this wire again by its knuckle, and at the end we could reach the true lumen and stenting for this long segment, and we got TEMI3 flow, and this is the follow-up after 9 months. We can appreciate that this vessel is constantly patent with the all branches along the course of the occlusion. So what is new in this technique now? At least we have a better understanding of the trauma to the subintimal space, and trying to make this trauma a little bit softer with the soft polymeric wires, and try avoiding subintimal hematoma. More directable wires with more antegrade wire escalation and parallel wire techniques than going straight away for antegrade dissection reentry. More low profile microcatheters like a Caravelle and Turnpike LP, which a little bit have a small profile in the subintimal space, and softer crossing profile, so a little bit less trauma. Of course, we have new devices like Stingray and Crossboss, which use a blunt dissection and directed re-entry in the from the subintimal space to the true lumen. So Crossboss, of course, is a blunt catheter, which make a blunt dissection, and this blunt dissection will avoid the subintimal or adventitial trauma, and avoid a big hematoma in the subintimal space. And this will allow you to redirect your wire after crossing the distal cap, and minimize the distal lumen compression. And of course, this device has energized the use of the antegrade dissection reentry. This is the Crossboss catheter, which is 1 millimeter tip blunt tip atraumatic catheter with a blunt dissection. And this is the flat balloon, which is a Stingray balloon with the 2 exit perpendicular pores, and each one directed opposite to the other. So this is a catheter used to direct your wire for re-entry, and this is how to adjust your Stingray. If you are looking on the left side, this is the way you should align your balloon, make it straight, not around the shape like on the right side. So this is the suitable projection for re-entry by the Stingray balloon, and try to avoid the right side one. In this trial, comparing the failed CTOs previously failed CTOs and retrial by Stingray cross-post system, which showed a good successful results, and at least 87% success in this trial with the failed CTOs. This is an example of case with a failed previous trial by not an experienced operator for CTO. This is a multi-vessel disease patient, comes with an unstable angina, and the operator tried to cross this vessel by a simple wires tried by pilot 50, and this is again by he crossed by pilot 150, and he didn't recognize that this wire in the subintimal space started to do an inflation in the subintimal space, and after tried this, he put another wire in the diagonal branch, and he find himself that he has a distal perforation in this diagonal branch, and this is why he stopped the procedure, not recognizing that the wire in the subintimal space in the LAD. So after this perforation, patient went into tamponade, and we called the surgeon for operating on this patient, but they preferred to wait for at least 3 months after this dissection in the LAD, and the patient remained unstable in the CCU. So we have to do something for this patient, and we tried again to cross this CTO of the LAD traditionally by anti-grade wire escalation. So after trying by different wires, Gaia wires, Conx wires, all of them are going to the subintimal space. And if you look in this projection, you may thought that this microcatheter, this is a fine cross microcatheter, are in the true lumen, but in other projection, you will find that this fine cross is outside the true lumen totally. So we found ourselves in a good plane in the subintimal space. So advancing this flat balloon or this Stingray balloon with the 2 dots into the subintimal space with trying of re-entry. So we used an anti-grade dissection re-entry with a many star technique. And this is a Confianza Pro 12 wire penetrating or piercing the distal true lumen after the distal cap, and confirming the position of the wire in the true lumen by different injection, and doing PTCA, stenting of this vessel, and this is the final result with good TEMI3 flow, and you can see that all branches coming from the LAD. So we are in the true lumen after doing a short segment of anti-grade dissection re-entry. Of course, we are obliged in this case. This is a failed case and retrial case. So Stingray is a good device for such cases. You can re-enter, and of course, we don't tackle this diagonal. Again, this is an algorithm for doing a CTO. And if we are talking about the bail-out procedures, if you are failed to cross the CTO totally and you find yourself in the subintimal space, you don't know where is the point of re-entry. So this is called the deferred procedure or the investment procedure. At this time, you will do only balloon inflation and trying to get a TEMI3 flow. And after getting a TEMI3 flow, just minimize your stents only to the distal part of the occlusion, or just distal to the distal cap, and don't do a metal jacket or overstent this vessel, because this may close the point of re-entry again. And after getting a TEMI3 flow, you may find yourself with a TEMI0 or TEMI1 flow. This is an example again of a case with a difficult retrograde access.
Sorry, we'll just interrupt you just to have 5 minutes of discussion. Can we go back one slide? Because I want to take everyone's opinion around the panel. Although the European algorithm seems to be slightly complicated and less, or not as simple as the Western algorithm, I see it's quite intelligent, because this is exactly what we were talking. No, the one with the algorithm, with the European algorithm last year. You will see that once you're in the anti-grade wire escalation mode, you failed parallel wire still has an option, and this is essentially meant to be a means for finding, again, true to true cross. And you can see that this is very intelligently written outside the sort of oval rose circle where you have the different maneuvers that Tariq has elegantly summarized when you find yourself in the subintimate space. I think, and I will start with my personal opinion and go around the panel. I think the main advantage that comes with the Stingray system is the ability to re-enter in with minimal length of dissection. You don't have to dissect for a long segment, similar to what we get with the STAR technique, because we know the long-term results is essentially stent failure of around 50% at 1 year, which is slightly unacceptable or very unacceptable. The success rate you would get with a Stingray is in the range of 80 to 85% in experienced hand. It is an expensive device, but I think it has revamped the ADR strategy, made it much more reproducible and predictable. So it is essentially the recommended dissection or anti-grade dissection re-entry mode. Now you can see that wire-based ADR, be it mini-star or blast or otherwise, is essentially meant as a bailout strategy, because the reproducibility, again, success rate is in the range of 50 to 60% in the best hands, and there's a great element of chance. And I think this is this algorithm summarizes how we think about the subintimate space and re-entry methods. Now, Khalid Mandoor, what do you think? Khalid, are you still with us?
I think
Yep.
ADR using wire-based technique is completely not reproducible. So usually when using a wire filter family, they have a small knuckle, and they tend to do a small dissection and less hematoma. That we can see was a pilot with a larger knuckle and a bigger hematoma. But in the end, it's completely based on how lucky you are to be in distally in the true lumen, or to complete in a dissection plan till the end of the coronary. So if in Egypt the Stingray balloon and the crossbow system is not available everywhere, so probably if any operator found himself in a dissection plan with a large hematoma, I think doing a STAR and POBA and defer stenting is a good option, because we see a lot of stents which are in a dissected vessel, and the flow is TIMI 1 to TIMI 0. So probably till the Stingray and the crossbow system is available everywhere, I think doing the dissection using Filter XT or Filter FC, and then do STAR or POBA if we fail to go to the true lumen is better, and defer the stenting is better than and continue the case. And as Dr. Omar said, he encouraged everyone to start doing CTOs, but just with an MB that everyone needs to know when to stop. This is the most important thing to do.
Very good point. Yeah, that's very good point. Yeah.
Dr. Nabil?
Thank you, Ahmed, for this important comment and important message to the attendees, because actually, usually I said that thanks to technology, the availability of the Stingray system helped us very much in doing the ADR successfully, with more success rate. But the problem, as Dr. Khalid mentioned, is the cost and unavailability in every center with this Stingray system, cross-pass. It's very important for those who are doing the AGR or subintimal tracking and reentry, it's very important to know which wire has to be used and to know has to has an experience in doing this if they don't have this Stingray system in the CAS lab. You know, this is a European algorithm for instant CTO, and they mentioned you know the crossboss mentioned very simply in this algorithm, and you can use. But I think in a country like Egypt and even in Turkey, the unavailability of such important device in every center, I think in view centers we have it. We have to know very well how we can use the simple techniques, simple wires and simple techniques for this AGR and STAR technique.
Very well. Omar, any comments or thoughts before we give the mic back to Tariq?
Yes, I'd like to thank you, Tariq, for this excellent, talk. He summarized everything. I like it. So, as as expert seat operator, I think we need Stingray for sure. We have to have that device in our lab because we need it, especially if we have very long and calcified RCA occlusion, from the proximal to the distal. Definitely Stingray help a lot. You can shorten the procedure time. And also, for example, the thing that Sheriff case, right? So he did it with parallel wire technique. If he failed, then he will go, maybe he will do some knuckle wire technique, right? If he can't find the true lumen with knuckle wire with the mini-star technique, then in routine case, we are looking for the retrograde collaterals. If we have good ones, that's okay. We have good chance to finish the case with retrograde. If not, then either we do Stingray technique, which is, I think, very good technique in some cases, or if we don't have good option for retrograde technique, we could do mini-star technique with investment, right? We do star technique, but to do only ballooning, not put a stent as Tariq mentioned. We can do that. I believe investment technique, we can do that if we don't have any option, right? Because if we fail from integrately, for the next time, we have low chance for success, with integrate. In that case, we do lots of integrate dissection. It's not easy to find a true lumen for the next attempt again. So in that case, I think we can do investment technique. We can do star technique. We can find one of the branches at the distal. We can do ballooning, and we just wait 1 or 2 months to see the result. So, but Stingray technique, we should have Stingray balloon in our lab for sure.
Excellent comments from all the panel. I just want to draw everyone's attention that sometimes expensive equipment eventually end up, besides securing success, they actually end up being more cost effective. So one thing we've said with rotational atherectomy, for instance, earlier on is when you think rotablating early on before using cutting balloon, a couple of non-compliant balloons that rupture, and eventually ending up in an acute situation with an abrupt closure of the vessel, and you really have to use a rotational atherectomy in a complex situation, or even worse, end up with a poorly expanded stent, is obviously not cost effective either on the short or the long terms. Similarly, the Stingray balloon is expensive indeed, but it will secure, in many occasions, success in a reproducible fashion, and will probably save you the cost of having to go retrograde with the risk that comes with going retrograde, especially if it were less than straightforward collaterals. And this is similar to what Dr. Sharif, for instance, mentioned earlier on, is the CTO, the progress complications score. So remember that whenever you choose to go retrograde, this comes at the risk of increased complications. This is particularly true if the retrograde options are not the greatest. So yes, it's an expensive device, but expensive devices, they occasionally end up saving cost beside avoiding complications, which is something we're advocating for. Tariq, sorry, we've interrupted you midways, but please carry on.
Now, of course, this is a very important thing for discussion of this a difficult topic. Of course, this is an example of a long CTO in the right coronary artery with a little bit poor collateral filling. This is a very difficult collateral to cross with a tortuous course. So in such case, if you are talking about the Stingray, if we have a Stingray, of course, it will be a cost effective, as in such case, you might use a lot of microcatheters, not only one microcatheter. You may try a Corsair, then a low profile one, then an anti-grade one. So you will use at least 2 or 3 microcatheters in such case with a lot of wires to cross retrogradely, and at the end, you will not able to cross these collaterals because of the tortuosity. And here you might think that you are in the PDA. Of course, by injection, you will find that you are outside of the vessel architecture. And if you look at this injection, you'll find that this collateral is very tortuous, although it's an septal connection. It's a very tortuous one with a lot of angulation. So reaching this collateral was very difficult. And again, crossing is very difficult. And at the end, it gives a mesh of tiny connections to the PDA, and this is uncrossable. Again, if you cross by the wire, you are not able to cross by the microcatheter. And at the end, again, the anti-grade access is the available one. And of course, this is a long occlusion. And going through the true lumen or in intimal space from true to true is very difficult. So going to the subintimal space and knuckling the subintimal space till the end of the vessel, and here you will find yourself at the very distal part of the vessel in one of the branches of the PDA, and you don't know where is the spiral dissection going to the true lumen. It's one of the branches here comes from the true, and the other comes from the inside the dissection flap. So you don't know where is the point of going to the true lumen. And if you are putting a lot of stents here in this vessel, you will find yourself with, again, TEMI 0 flow or TEMI 1 flow maximum, because you close all the branches by this spiral dissection. So in such case, the deferred strategy is the best, or the investment strategy, and doing a PTCA for the whole vessel and only stenting the totally occluded part. And this is the end result. You will find the haziness at the distal edge of the stent, but this haziness is going through the vessel course. Don't try to put a lot of stents till the end of the vessel, because after getting a TEMI 3 flow, you will find yourself with an ORI flow. So keeping this patient for at least 6 weeks and study the patient with an angiography, you will find only a small part to be stented at the distal part of the stent. And here you got a TEMI 3 flow in both vessels with a good branches supplying the myocardium, and you have a good flow through this vessel. So if we go back at the first procedure, if you are going to stent, you are going to stent till the PDA, and if you are stented the vessel from the proximal to the distal end, you will increase the possibility of restenosis. It will be more than 50%. You might have only a TEMI 1 flow, and you will lose a lot of branches. So only stent the part of the occlusion till the distal cap, and don't try to go beyond this. If you are going beyond this, you will get a worse flow, and bring your patient back in at least 6 weeks and not more than 3 months, this is preferably stent only the remaining part of dissection or the diseased part of the vessel. And here we put only a focal stent in the second procedure with a good TEMI 3 flow. Of course, this is one paper addressing the issue of deferred stenting, and they address that this technique, deferred stenting by star technique, is safe and effective for complex CTOs when other techniques are prohibited or they failed, other techniques failed. And this is one paper done by Galassi assessing these bailout techniques, and they found that the main target to get is the TEMI 3 flow. If you have a TEMI 3 flow, so you are safe to keep the patient for the second procedure in 6 weeks, and don't try to put a lot of stents. And the main predictor of long-term outcome in such procedures is the TEMI 3 flow. The TEMI flow is the main predictor of long-term outcome. This is again another technique, but I don't think it's a reproducible technique, which is antegrade fenestration and re-entry, trying to go by in the subintimal space, doing a balloon inflation and getting another wire, preferably a polymer jacket wires, and while deflating the balloon, try to advance this wire. You may enter through these dissection flaps into the true lumen, but of course this is a non-reproducible technique, and still they are trying to assess this technique. Of course, just to mention, the parallel wire technique is a midway between the antegrade wire escalation and the antegrade dissection reentry, and I don't want to go for more details, as Dr. Sharif gave us a good example for this technique. This wire to align the vessel and to straighten the vessel, to give you a roadmap about the vessel. For the second wire, to use a more stiffer wire for crossing this CTO. So ADR, of course, evolved over time with initially with the star contrast-based last and done effectively by a cross-boss Stingray system. Should minimize your contrast injection from the anti-grade guide. Anti-grade dissection reentry still remained unpredictable in long and acute term results. And thank you.
Thank you very much, Tariq, for a comprehensive overview. I was under the impression this was going to be a case presentation, but you actually made this quite lively and perhaps covered different aspects of ADR in detail. Thank you very much. I think we can spare just 1 minute of comments from the panelists. Any last minute thoughts? We can start by Dr. Omar Bektakin.
The first of all, I'd like to share the our situations meeting announcement, my dear. It will be next week. We have excellent lab cases. I hope all attendants will join this meeting next week. So I'm very happy to join tonight. You know, we discussed very important point tonight, and I think, you know, we have to separate CT operators like CT operators and expert CT operators, and any moderate intervention cardiologist can be CT operator in my mind. So I think we should push and encourage our colleagues to do more CTO cases in future.
Thank you, Omar. Dr. Nabil.
Thank you, Ahmed, for this excellent meeting, and I would like to thank you for the first presentation. I'm not lucky to attend it. Dr. Sharif for his nice presentation about the parallel wire technique and wire escalation, and Dr. Tariq for this comprehensive presentation about the ADR technique. Actually, all of them were very educational, and I hope the attendees have learned a lot from this. I would like just to send a message for the young doctors who want to start the CTO program, that they have to read. They have to read about everything about CTO. CTO is not only practicing CTO. It is a science that we have to know, and we have to read about it. We have to know everything about the wires we are using, the anatomy of every wire, the indication, and when to use every wire. We have to know the microcasters and different microcasters and the advantage of one microcaster over the other, and when to prefer one microcaster over other when we are doing whether anti-grade or retrograde approach. And then going to the different techniques, starting with the anti-grade approach techniques, then retrograde approach, and they have to know the toolbox that should be available in the CAST lab who started this CTO program. It is not as simple as they watch. It should be done properly to have a success rate like expert centers. We can have a success rate more than 90% in even difficult CTO cases. If we know everything about the CTO, we know the wires, the casters, the device we use, and the different techniques, and also very important to have a very good experience in doing this very difficult and tough case.
Thank you, Dr. Nabil. Dr. Muhammad Atif? Atif, please unmute yourself.
I think I'm unmuted. You hear me right now? Okay. Thank you, Ahmed, and welcome, Dr. Nabil. Good to see you.
Welcome, Hamid.
And thank you for the presenters, of course, and Dr. Omar. I have one short message, is just to remember to use a wire that you are can communicate with, or can you navigate with easily. You don't have to use every single wire, because you have big families and very, very big groups of wires. So try at least to be familiar with one wire in each group. The other thing is you have to remember that failure is an option. Failure to cross the CTO is still an option. By time you can have more experience and have to have more success in your cases. Me, myself, I have a good, to see that one patient I've done 10 years before with a CTO on the right coronary. And at that time, I told him just go for medical treatment. And he's back 7 years later with another. I tried good success in one, and like a couple of months ago, I finally succeed to open the last CTO one. So it's a matter of years, matter of experience. Failure is an option to learn from your failure and try to increase your success rate by time. Thank you very much for this nice meeting, and hope to see you soon, inshallah.
Thank you, Khalid Mandoor. Dr. Khalid, unmute yourself, please.
I would like to thank all the panelists and the speakers for this excellent meeting. And I have only one comment about Dr. Sharif case, about using the dual lumen microcaster if you're in a dissection plan. It's a question at the same time as with your presence. So if the wire is in the dissection plan, and we are using, and we don't know where the dissection started, so if the dissection is at the proximal cap as the last case, I think using a dual lumen microcaster, which is a very bulky microcaster, will increase the hematoma, and it's likely going to increase the failure rate of recrossing to true lumen. So I think using the dual lumen microcaster is only if you're very close to the true lumen. If you know that you're very close to the true lumen, like 1 millimeter, 1.5 millimeter to the true lumen, and you can use a dual lumen microcaster. But if the wire is completely far away from the true lumen, using a dual lumen microcaster will just increase the failure rate due to the hematoma that the dual lumen microcaster will do. I don't know if you agree with me about this or not.
For me,
I
I agree
actually
with
beg to differ, but perhaps we can leave this for the discussion in the next wave,
Yes.
and that can be a good opener as a comment and a question.
Yes.
Now I think we're overdue our time, and I want to thank the co-chair of the program, Dr. Omar Göktekin, my dear friend and colleague Tariq Rashid, Dr. Sharif Al-Biltagi for the wonderful presentations, Dr. Nabil Farag, Dr. Muhammad Atif, Dr. Khalid Mandoor for the excellent comments and for their moderation. I also want to ask you to please join us for the second wave of our complex CTO PCI series, or complex PCI series. The second wave is also going to be on CTOs. This is going to be on the 26th at 7 p.m. So please join us. I have to thank Medtronic for making all of this possible and bringing us all together. Most importantly, I want to thank the attendees for taking this out of their time. And I will join Omar in his note to everyone. Try not to miss the 11th CTO Essentials meeting taking place next week. I have seen the program. It's an excellent program with expert speakers from all over the world, plus the live transmissions from very experienced and high volume centers. So please do try to join us. And thank you everyone for the questions and for interacting and for being here today. Thank you so much, everyone.
Thank
Good
you
night.
very much. Good night.
Thank you. Bye-bye.
Goodbye.